Hi everyone, this is Dr. Ina Irabon and this is my updated lecture on abnormal labor. To download my lecture deck, please go to my WordPress site, Ina Obigaine. Reference for this lecture is the latest edition of Williams Obstetrics 25th edition. And here's the outline of my lecture. So the term dystocia literally means difficult labor or dysfunctional labor. And this is characterized by abnormally slow labor progress. Some experts would choose the term cephalopelvic disproportion or failure to progress in relation to dystocia. Dystocia arises from three distinct abnormalities, and that is what we call the 3Ps of dystocia, that may exist singly or in combination. So these 3Ps are power, passenger, and passages. Power, of course, refers to the expulsive forces that may be abnormal, and this may be secondary to inadequate uterine contractions or inadequate voluntary maternal muscle effort during the second stage of labor. For the passenger, this may refer to the fetal abnormalities of presentation, position, or fetal development. And of course, the passages would refer to abnormalities of the maternal bony pelvis that may create a contracted pelvis, or soft tissue abnormalities of the reproductive tract that may form an obstacle to fetal descent. Here are some common clinical findings in women with ineffective labor. So some would have inadequate cervical dilatation or fetal descent, secondary to protracted labor or slow progress of labor, arrested labor, or no progress in labor, or inadequate expulsive effort secondary to ineffective maternal pushing. Some may have fetopelvic disproportion secondary to excessive fetal size, inadequate pelvic capacity, malpresentation or position of the fetus, or abnormal fetal anatomy. And some would have ruptured membranes without labor. So in our book, Williams Obstetrics, the authors beautifully classified abnormal labor patterns into three. So these are prolongation disorder, protraction disorders, and arrest disorders. And under each labor pattern, we have a specific subtype. So, for example, under prolongation disorder, we have prolonged latent phase. Under protraction disorders, we have protracted active phase of dilatation or protracted descent. And then for arrest disorders, we have four subtypes. We have prolonged deceleration phase, secondary arrest of dilatation, arrest of descent, or failure of descent. Now, in the next column here, we have the diagnostic criteria for nulliparous and multiparous. So, for example, to diagnose prolonged latent phase, there should be a prolongation of the latent phase to at least or more than 20 hours for nulliparous and for more than 14 hours for multiparous. So the third column here will be the preferred treatment or the first-line treatment for each abnormal labor pattern involved. So for example, for prolonged latent phase, the preferred treatment will be bed rest. So the fourth column here will be the exceptional treatment or the alternative treatment. So for example, for prolonged latent phase, we can start oxytocin drip or do cesarean delivery only if we see other urgent problems. So let's talk about the 3Ps. Okay, the first P will be power, and this will be the abnormalities of the expulsive forces. So experts emphasize that uterine contractions of normal labor are characterized by a gradient of myometrial activity. And these forces are greatest and last longest at the fundus, which we call fundal dominance. And they diminish downward towards the cervix. So they also reported that in addition to a gradient activity, the onset of the contractions differed in the fundus, mid-zone, and lower uterine segments. And these stimulus start in one cornu and then several milliseconds later in the other cornu. So the excitation waves, they join in the middle and then sweep over the fundus and down the uterus towards the cervix. So normal spontaneous contractions often exert pressures approximating about 60 mm Hg. However, the lower limit of contraction pressure that is required to dilate the cervix is just about 15 mm Hg. And experts have defined that adequate uterine contractions should be at least 200 Montevideo units in a period of 10 minutes. So how do we compute for the Montevideo units? Of course, we compute the Montevideo units only for a patient who is in active labor. Okay, so first off, we have to generate a 10-minute fetal strip like so. Okay, so in this fetal strip, we see that there are about 5 uterine contractions. Okay, so the upper panel here will be the fetal heart rate pattern. And then we look at the individual pressure that is generated by each contraction. Okay, so for example, in this contraction here, we compute for the pressure, and that will be about 50 millimeter Hg. How did we get that? Of course, we subtract the baseline pressure from the peak contraction pressure. So in this case, this is about 60 millimeter Hg minus 10 millimeter Hg. So that's about 50 millimeter Hg. Okay, so we add all the individual contraction pressure, and then the sum of those will be the total Montevideo units. So there are two physiological types of uterine dysfunction. The first, of course, is hypotonic uterine dysfunction, where there is no basal hypertonus and uterine contractions have a normal gradient pattern, but the pressure during a contraction is insufficient to dilate the cervix. The next is hypertonic uterine dysfunction or incoordinate uterine dysfunction. There's either the basal tone that is elevated appreciably or the pressure gradient is distorted. Gradient distortion may result from more forceful contraction of the uterine midsegment than the fundus or from complete asynchrony of the impulses originating in each cornu or a combination of these two. So what is latent phase prolongation? Latent phase prolongation is defined as latent phase that is more than 20 hours in nulliparous or more than 14 hours in multiparous. And as you have already seen in the table shown earlier, this is often managed with bed rest, or some would prefer starting oxytocin stimulation. Active phase disorders are divided into two. No? It can be protraction disorder or a slower than normal progress in labor, or an arrest disorder or a complete cessation in the progress of labor. For us to be able to diagnose an active phase disorder, the woman or the parturient must be in the active phase of labor, which is defined by cervical change. Now let's talk about these two active phase disorders. For active phase protraction, the WHO defines this as a rate of cervical dilatation of less than 1 centimeter per hour for a minimum of 4 hours. And the preferred treatment, of course, will be observation of further progress. If the Montevideo units are insufficient, then we could start oxytocin drip to augment labor. Slow but progressive first stage of labor should not be an indication for cesarean delivery. For active phase arrest, this is defined as no cervical dilatation for at least 2 hours. And the requirements should be the following: that the latent phase should be completed, cervix is dilated to at least 4 centimeters, and the uterine contraction pattern must be at least 200 Montevideo units in a 10-minute strip, and that has been present for at least 4 hours. Here are 4 recommendations by the Obstetric Care Consensus Committee applicable to the management of the first stage of labor. The first is a prolonged latent phase should not be an indication for cesarean delivery. A slow but progressive labor or a protraction disorder is not an indication for cesarean delivery. Active labor starts at cervical dilatation of 6 centimeters and not 4 centimeters. And cesarean delivery for active phase arrest should be reserved for women at or beyond 6 centimeters of cervical dilatation with ruptured membranes who fail to progress despite 4 hours of adequate uterine activity or at least 6 hours of oxytocin administration. So the question now is, why have experts now shifted to recommending 6 centimeters as the threshold for active labor instead of the traditional 4 centimeter threshold for active labor? A review of selected publications helps explain the consensus committee evolution to the 6 centimeter rule. It was actually Zhang and co-workers who compared a study population from one report by Friedman in 1955 with one from the study that was done in Tripler Army Hospital in Hawaii. Okay, so in this study, they showed that the progress of labor is slow between 4 and 6 centimeters. However, the progress of labor accelerates after 6 centimeters. Now, this could reasonably be interpreted as the active phase beginning at 6 centimeters. So, the 6 centimeter rule for active labor derives from a slowing of the rate or flattening of the slope of cervical change in the first stage of labor. So the second stage of labor incorporates many of the cardinal movements necessary for the fetus to negotiate the birth canal. And accordingly, disproportion of the fetus and pelvis frequently becomes apparent during the second stage of labor. So similar to the first stage of labor, time boundaries have been supported to limit the second stage duration to minimize adverse maternal and fetal outcomes. So the second stage in nulliparous is limited to 2 hours and extended to 3 hours if with regional anesthesia. The second stage in multiparous is about 1 hour but extended to 2 hours if with regional anesthesia. Now, the Consensus Committee of 2016 recommends allowing a nullipara to push for at least 3 hours and a multipara to push at least 2 hours before the second stage labor arrest is diagnosed. However, we should be very sure that maternal and fetal status are very good. So what are the reported causes of uterine dysfunction or the reported causes in the abnormality in powers? First, of course, is starting epidural analgesia very early into labor. Epidural analgesia can slow down labor, and this is associated with lengthening of both first and second stage of labor and with slowing of the rate of fetal descent. Infection in the form of chorioamnionitis can also slow down labor. An infection diagnosed late in labor was found to be a marker of cesarean delivery performed for dystocia, whereas this was not a marker in women diagnosed as having chorioamnionitis early in labor. Now we go to the second P, which is passages, and this usually refers to fetopelvic disproportion. Fetopelvic disproportion arises from diminished pelvic capacity, excessive fetal size, or usually both. Okay? There may be a contraction of the pelvic inlet, the midpelvis, or the pelvic outlet, or generally contracted pelvis may be caused by combinations of these. So let's talk about the contracted inlet. Using clinical measures, it is important to identify the shortest EP diameter through which the fetal head must pass. Before labor, the fetal biparietal diameter averages about 9.5 to 9.8 centimeters, and therefore it might prove difficult or even impossible for some fetuses to pass through the pelvic inlet that has an EP diameter of less than 10 centimeters. So employing X-ray pelvimetry, when the shortest EP diameter is less than 10 centimeters or if the greatest transverse diameter is less than 12 centimeters, then we describe that or we diagnose that as a contracted pelvic inlet. However, these days we don't do much X-ray pelvimetry anymore. What we use today or these days will be clinical pelvimetry. So, the anterior-posterior diameter of the inlet is actually the obstetric conjugate, shown in this picture here in red. Okay, so this is commonly approximated by manually measuring the diagonal conjugate, which is shown here in blue. Okay, so the diagonal conjugate is about 1.5 centimeters longer than the obstetrical conjugate, and therefore, we measure the obstetrical conjugate by subtracting 1.5 centimeters from the diagonal conjugate, right? So, clinically, we define contracted inlet as a diagonal conjugate of less than 11.5 centimeters. Normally, cervical dilatation is aided by hydrostatic action of the unruptured membranes or after the rupture by direct application of the presenting part against the cervix. However, in a contracted pelvis, because the head is arrested in the pelvic inlet, the entire force exerted by the uterus acts directly on the portion of the membranes that contact the dilating cervix. So, early spontaneous rupture of the membranes is more likely. So, after membrane rupture, absent pressure by the head against the cervix and the lower uterine segment predisposes to less effective contractions. So, further dilatation may proceed very slowly or even not at all. In women with contracted pelvis, face and shoulder presentations are encountered 3 times more frequently and the cord prolapses 4 to 6 times more often. So now let's go to contracted midplane or midpelvis. This is more common than the inlet contraction and it can cause transverse arrest of the fetal head, which potentially can lead to a difficult mid-forceps operation or to cesarean delivery. The midpelvis extends from the inferior margin of the symphysis pubis through the ischial spines and touches the sacrum near the junction of the fourth and fifth vertebra. The average midpelvis measurements are as follows. So we have the interspinous diameter, which is this line, which is about an average of 10.5 centimeters. The AP diameter, which is this line, which is an average of about 11.5 centimeters. And the posterior sagittal diameter, which is this line here, which is about 5 centimeters on the average. So the midpelvis is likely contracted when the sum of the interspinous and the posterior sagittal diameters is less than 13.5 centimeters or when the interspinous diameter is less than 8 centimeters. Other midplane findings that suggest midplane or midpelvis contraction would be the following: when the spines are prominent, when the pelvic side walls converge, or when the sacrosciatic notch is narrow. Narrowing of the interspinous diameter can be anticipated when the intertuberous diameter is narrow. A normal intertuberous diameter, however, does not always exclude a narrow interspinous diameter. Then lastly, we have a contracted outlet. So a contracted outlet is often defined as an interischial tuberous diameter of 8 centimeters or less. A contracted outlet may cause dystocia not so much by itself, but by an often associated mid-pelvic contraction. Outlet contraction without concomitant midplane contraction is rare, and contracted outlet often gives rise to perineal tears. Now we go to the third P, which is the passenger. Fetal-pelvic disproportion can also arise from large fetal head size or malposition of the fetal head, such as in cases of asynclitism, occiput posterior position, face or brow presentation. Now, there is a maneuver which we call the Mueller-Hillis Maneuver, which is traditionally used to predict dystocia. So, this is when the fetal brow and the suboccipital region are grasped through the abdominal wall with the fingers, and firm pressure is directed downward in the axis of the inlet or the birth canal. Now, if no disproportion exists, the head readily enters the pelvis and the vaginal delivery can be predicted. Now, there is also what we call the modified MHM or modified Mueller-Hillis maneuver, where the Mueller-Hillis maneuver is used only during the second stage of labor during a contraction. There's also another maneuver we call the Munro-Kerr maneuver or MKM. It's actually the same as the Mueller-Hillis maneuver. However, in this maneuver, you see here that the thumb, we place the thumb over the symphysis pubis to note the degree of overlapping of the head over the symphysis pubis. So for face presentation, this is rarely delivered vaginally. You see here that the head is hyperextended, right? So that the occiput is in contact with the fetal back and the chin or mentum is presenting at the birth canal. The fetal brow or bregma is pressed against the symphysis pubis, and this position precludes flexion of the fetal head, which is necessary, of course, to negotiate the birth canal. Remember the cardinal movements of labor. We need the head of the fetus to flex in order to negotiate or traverse the birth canal. Thus, a mentum posterior presentation, such as in this picture that you see here, is undeliverable vaginally, except, of course, in cases where we have very preterm fetuses. However, term fetuses with face presentation in mentum anterior, meaning the mentum is here, anteriorly and not posteriorly, vaginal delivery is possible. What is the etiology of face presentation? Now, this includes conditions that favor extension or prevent head flexion, and this can include preterm infants with their smaller head dimensions that can engage before conversion to vertex position, marked enlargement of the neck or coils of cord around the neck which may cause extension, fetal malformations or hydramnios, anencephalic fetuses that naturally present with face presentation, pelvis that is contracted or the fetus is quite large, or high parity. No? Pendulous abdomen permits the back of the fetus to sag forward or laterally, which promotes extension of the cervical and thoracic spine. So how do we manage such cases? No, because face presentations among third-size fetuses are more common when there is some degree of pelvic inlet contraction. Therefore, cesarean delivery is frequently indicated. Now, attempts to convert a face presentation manually into a vertex presentation and internal podalic version and extraction are dangerous and should not be attempted. Now we go to brow presentation. This is diagnosed when the portion of the fetal head between the orbital ridge and the anterior fontanelle presents at the pelvic inlet or the birth canal. The fetal head thus occupies a position midway between full flexion and extension. Now, engagement of the fetal head and subsequent delivery cannot take place as long as the brow presentation persists, except of course when the fetal head is small or the pelvis is unusually large. And then we have transverse lie. So, in a transverse lie, the long axis of the fetus is perpendicular to the long axis of the mother, and the shoulder is usually positioned over the pelvic inlet. The head occupies one iliac fossa and the breech the other iliac fossa. So this creates a shoulder presentation in which the side of the mother on which the acromion rests determines the designation of the lie as right or left acromion. What are the causes of transverse lie? Well, these are the common causes, no? Abdominal wall relaxation from high parity, preterm fetus, placenta previa, abnormal uterine anatomy, hydramnios, and contracted pelvis. A relaxed and pendulous abdomen allows the uterus to fall forward, deflecting the long axis of the fetus away from the axis of the birth canal and into an oblique or transverse position. We also have the neglected transverse lie. So after rupture of the membranes, the fetal shoulder is forced into the pelvis and the fetal arm prolapses. So the shoulder is arrested by the margins of the pelvic inlet with the head in one iliac fossa and the breech on the other. So the uterus contracts vigorously in an unsuccessful attempt to overcome this obstacle. So with time, a retraction ring, such as you see here, no, this red marks here, this is what you call the pathological ring of Bandel, rises increasingly higher and becomes more marked. With this neglected transverse lie, the uterus will eventually rupture. The transverse lie is usually an indication for cesarean delivery. So before labor or early in labor with the membranes intact, attempts at external version are worthwhile in the absence of other complications. Now with cesarean delivery, because neither the feet nor the head of the fetus occupies the lower uterine segment, a low transverse incision into the uterus may lead to difficult fetal extraction. And therefore, instead of a low transverse incision, we do a vertical or a classical incision. So if the fetus is small, like it just weighs less than 800 grams and the pelvis is quite large, then vaginal delivery is still possible. Fetus is compressed with the fetal head forced against its abdomen. Okay, so the portion of the thoracic wall becomes the most dependent part, therefore appearing at the vulva. And so the fetus is doubled upon itself, and this is what we call conduplicato corpore. So next, we have the compound presentation. So in a compound presentation, an extremity prolapses alongside the fetal presenting part. So in this case, now in this picture that we have here, we have the fetal hand prolapsing alongside the head. Okay, so causes of compound presentations are conditions that prevent complete occlusion of the pelvic inlet by the fetal head, including preterm labor. So how do we manage these cases? So in most cases, the prolapse part should be left alone because most often it will not interfere with labor. Now, if the arm is prolapsed along the head, The condition should be observed closely to ascertain whether the arm retracts out of the way with descent of the presenting part. Now, if it fails to retract, and if it appears to prevent descent of the fetal head, then the prolapsed arm should be pushed gently upward and the head simultaneously downward by fundal pressure. In general, rates of perinatal mortality and morbidity are increased as a result of concomitant preterm delivery, prolapse cord, and traumatic obstetrical procedures. So now we go on to discussing complications of dystocia. So first, maternal complications. So number one will be uterine rupture, and this is usually secondary to the abnormal thinning of the lower uterine segment during prolonged labor. Women with high parity and in those with the prior cesarean delivery are at most risk of uterine rupture. So when this proportion is so pronounced that there is no engagement or descent, the lower uterine segment becomes increasingly stretched and rupture may eventually follow. So as I've already mentioned a few slides back, the pathological retraction ring of Bandel, which is this part here, is associated with marked stretching and thinning of the lower uterine segments, such as in cases of neglected transverse lie. The ring may be seen clearly as a uterine indentation, as you see in this picture here, and signifies impending rupture of the lower uterine segment. So here again is a picture of the pathological retraction ring of Bandel. Next maternal complication is fistula formation. So with dystocia, soft tissues of the birth canal lying between the leading part and the pelvic wall may be subjected to excessive pressure. And because of impaired circulation, necrosis may result and become evident several days after delivery as vesicovaginal, vesicocervical, or rectovaginal fistulas. Third complication is pelvic floor injury. Now, during childbirth, the pelvic floor is exposed to direct compression from the fetal head and to downward pressure from maternal expulsive efforts. And these forces stretch and distend the pelvic floor, resulting in functional and anatomical alterations in the muscles, nerves, and connective tissues, and thus leading to urinary incontinence and pelvic organ prolapse. Next maternal complication is postpartum lower extremity nerve injury, and the most common mechanism is because of external compression of the common fibular, formerly common peroneal nerve. And this is usually caused by inappropriate leg positioning in the stirrups, especially during prolonged second stage of labor. Fortunately, symptoms of lower extremity nerve injury resolve within 6 months of delivery, especially with the help of physical therapy. Other maternal complications can include infection, intrapartum chorioamnionitis, or postpartum pelvic infection, and postpartum hemorrhage, which is secondary to atony due to prolonged and augmented labors. So how about perinatal or fetal complications? The baby can have caput succedaneum, or swelling or edema of the fetal scalp, molding, leading to abnormal head shape, or mechanical trauma such as nerve injury, fractures, and cephalhematoma. So in the past few slides, we have been talking about slow progress or arrest in the progress of labor. On the other end of the extreme, we have what we call precipitous labor and delivery. And a precipitous labor and delivery is an extremely rapid labor and delivery. It may result from an abnormally low resistance of the soft parts of the birth canal, from abnormally strong uterine and abnormal contractions, or rarely from the absence of painful sensations and thus a lack of awareness of vigorous labor. Precipitous labor terminates in expulsion of the fetus in less than 3 hours from the onset of labor. What are the maternal effects of precipitous labor and delivery? Vigorous uterine contractions combined with a long, firm cervix and a non-compliant birth canal, of course, may lead to uterine rupture or extensive lacerations of the cervix, vagina, vulva, or perineum. It is in these latter circumstances that the rare condition of amniotic fluid embolism most likely develops. Precipitous labor is frequently followed by uterine atony, where the uterus that contracts with unusual vigor before delivery is likely to be hypotonic after delivery, and therefore postpartum hemorrhage may ensue. Short labor is defined as a rate of cervical dilatation of 5 centimeters per hour or faster for nulliparous or 10 centimeters per hour for multiparous, and this is associated with placental abruption, meconium staining, postpartum hemorrhage, cocaine abuse, and low Apgar scores. What are the fetal and neonatal effects of precipitous labor and delivery? Of course, tumultuous uterine contractions, often with negligible intervals of relaxation, can prevent appropriate uterine blood flow and fetal oxygenation. And so, Acker and his co-workers reported that Erb or Duchenne brachial palsy may be associated with precipitous labor and delivery. During an unattended birth, the newborn may actually fall to the floor and may be injured, or it may need resuscitation that is not immediately available. Okay, so that's the end of my lecture on abnormal labor. So in summary, we've talked about the definition of dystocia, the three P's of dystocia, which are power, passenger, and passages. We talked about the etiology of dystocia, which is comprised of fetal-pelvic disproportion, pelvic capacity, face presentation, brow presentation, transverse lie, and compound presentation. We also talked about complications of dystocia, and lastly, precipitous labor and delivery. So thank you for listening and watching this lecture, and have a great day ahead.